Thank you, Bill, for that wonderful presentation. My name is Michael Curian. I'm a gastroenterologist at Virginia Mason Medical Center in Seattle. My presentation will be on the optimal use and future use of JAK inhibitors for the management of IBD. So this is the outline of my talk. In the first few minutes, I'll spend some time discussing the mechanism of action of JAK inhibitors and the importance of selectivity. Then we're going to review the clinical efficacy data and safety data for JAKs in inflammatory bowel disease. And at the end, I'll spend some time discussing the positioning of JAK inhibitors in the management of IBD. The modern approach to the management of inflammatory bowel disease is a risk-based strategy. As you can see here, based on the disease severity, we have sometimes to act quickly and efficiently for patients with severe disease, put emphasis on safety in patients with moderate disease, whereas for patients with mild disease, other issues may come to the front, such as the cost utility of the intervention or quality of life. And of course, the safety of the medication used varies in an inverse relationship. So these are the risk factors for severe disease on the left side for ulcerative colitis and on the right side for Crohn's disease. So if you browse over this, you will note that these risk factors point to the more acute character of ulcerative colitis. This is a disease that can turn south on a dime, whereas Crohn's disease is a bit more forgiving in the short term, but obviously it is a more punishing disorder through long-term complications in the long term. So with that, we'll talk about the use of JAK inhibitors in inflammatory bowel disease. And as you know, JAK inhibitors are small molecules, being very different from monoclonal antibodies, which we have used for some time, not just by their size, but also by their versatility. The JAK STAT pathway, which is the target of JAK inhibitors, is a very important intracellular signaling pathway for the immune system. And as shown in this diagram, when a cytokine binds to the extracellular receptor, this leads to the dimerization of the receptor, activation of the JAKs or the Janus kinases, which work in pairs. They basically activate the intracytoplasmic portion of the receptor that leads to the activation of another molecule called STAT, which is essentially the shuttle that transfers the message from the membrane from the cytokine to the nucleus, leading to the transcription and production, excess production of a number of pro-inflammatory cytokines that are shown in that right lower corner. So how do the JAK inhibitors work? By inhibiting the JAK, there is less phosphorylation, there is less activation of the STAT, and as a result, there is a signal inhibition of a large number of these pro-inflammatory cytokines at once. So as opposed to the monoclonals, which are generally targeted for a single pathway, JAK inhibitors work on multiple pathways. They're also different in that rather than being a turn off or a switch off molecule, they work more like light dimmers. Other properties, they have short half-life, fast onset, no immunogenicity. There's variable specificity, as we'll see, and due to their short half-life, drug levels are not relevant. So a very important subset of pro-inflammatory cytokines in the pathogenesis of both inflammatory bowel disease and rheumatoid arthritis use JAK pathways, as you can see there on the right. A notable exception here is TNF-alpha, which is signaled through a different intracellular pathway. But indirectly, TNF-alpha is also downregulated because JAKs tend to suppress the main sources of TNF-alpha, such as macrophages and T cells. Selectivity is another very important feature of JAK inhibitors. There are 4 JAK subunits named JAK1, JAK2, JAK3, and TYK2. And as you can see, JAK1 and TYK2 are more important for inflammation and autoimmunity. And JAK2 and JAK3 are a little more important for hematopoiesis, antiviral defense, and tumor surveillance. So the affinity of a certain JAK inhibitor for a specific JAK molecule is what essentially dictates the specificity for a certain pathway or a certain cytokine pathway, such that these agents can be actually tailored to be more effective for a certain disease, such as inflammatory bowel disease or rheumatoid arthritis, or as you can see in the middle, lupus, Behçet's, and so on and so forth. So the selectivity of a JAK inhibitor for a specific JAK molecule may be that fulcrum that dictates the balance between efficacy and safety. There are several JAKs, some available for use, some in production, some non-selective, some selective. Of course, the one that's currently available for use in ulcerative colitis is Tofacitinib. There are a number of selective JAK inhibitors that are in late stages of development, including Upadacitinib and Philgottinib that we're going to discuss about. And of course, Tofa has shown good efficacy for induction and maintenance therapy in patients with moderate to severely active UC. On the left side, you have the induction data from the phase 3 program showing significant superiority over placebo. And on the right side, the maintenance data with 2 different doses of Tofa, 5 milligrams and 10 milligrams, both showing significant superiority over placebo. What's important here, though, is if this is the induction data stratified by prior anti-TNF experience. So on the right side are bio-naive patients. On the left side were patients who had failed anti-TNF. And while the magnitude of response is higher in patients who are bio-naive, the important part here is that the therapeutic effect or the effect difference is very similar between bio-naive and bio-experienced patients, so that the likelihood of response or number needed to treat is actually very similar whether the patient is bio-naive and bio-experienced. And this actually plays out. We're going to talk about the positioning of this specific JAK inhibitor in the treatment paradigm. As far as the maintenance data is concerned, things are a little bit different. Here you see no significant or no difference between the 5 and 10 milligram dose all the way to week 52 among patients who are bio-naive, but a very nice dose response among patients who are anti-TNF experienced, suggesting that patients who have failed a TNF agent may require a higher dose of Tofacitinib for maintenance, such as 10 milligrams twice daily, compared to patients who are bio-naive. So therein lies your first predictor of response to Tofacitinib, and that bio-naive patients may be de-escalated a little more readily compared to patients who are bio-experienced. Another feature, another very important features of JAK inhibitor and Tofacitinib in particular is the speed of onset. So this is that need for speed in patients with severe UC. What you see here is basically the daily symptom score, stool frequency on the left and rectal bleeding on the right. And as you can see, the 2 curves are actually separating as early as day 3. They actually become significant as early as day 3, both in terms of number of bowel movements and rectal bleeding. So this feature has been basically used by some experts in IBD experts in expert centers, off-label, of course, and I'm saying off-label because the dose used in this study was 30 milligrams daily rather than the approved dose of 20 milligrams per day, to treat patients with acute severe ulcerative colitis who are hospitalized. And what's important to remember here in the background is these were patients who were actually failing systemic steroids, and the majority of them anti-TNF drugs. And not only that the symptoms improve, but if you look on the right side, you also have the biomarker, the CRP, which dropped precipitously. So by day 5, all patients had a substantial improvement in the CRP, and 3 out of 4 patients, at least in this case series, left the hospital with an intact colon. On the left side, this is reflected by one of the patients at our institution early last year. Very similar curve. Our patient's CRP actually normalized at day 3, obviously associated with a rapid improvement in the symptoms. So rapid onset, very important feature of JAK inhibitors. How about Crohn's disease? Well, things didn't look quite so rosy, at least for Tofa for Crohn's disease. Although if you look on the left side, you have the induction data. On the right side, you have the maintenance data up to 6 months. This is the phase 2 program. Again, 2 different doses, similar to the UC program. There was a numerical trend for response, including in patients who failed anti-TNF. but this did not meet statistical significance. Despite this, if you look here, the CRP in the induction trial, and both CRP and CalPro dropped significantly with both doses. So this is one of those situations where that pesky p-value and the CDAI derailed a development program. Nonetheless, the success with tofacitinib obviously bred a number of competitors. It's actually interesting because even if this paper was published last year, this table is already outdated. So where Tofa left off, other picked up, and this is the case with upadacitinib. This is a JAK1 selective inhibitor. This is data from the phase 2 program for Crohn's disease. Again, induction or week 16 results. On the right side, clinical remission. On the left side, endoscopic improvement. In both cases, you see a very nice dose response for remission and for endoscopic remission at 4 months. What's important here, though, is given the selectivity, we think that we were able to jack up the dose of, pun intended, of course, to jack up the dose of upadacitinib to much larger doses. And in fact, in the phase 3 program, the induction dose for UPA is 45 milligrams daily for both Crohn's disease and ulcerative colitis. Philgottinib is another JAK1 selective inhibitor, just wrapped up the phase 3 program for ulcerative colitis. This data was presented a few months ago at the UEGW. These are the results for the induction study, bio-naive patients on the left and bio-experienced patients on the right. Again, same story, a lower magnitude of response in patients who failed other biologic agents, but the effect difference was there, and there was a significant difference along with a dose response between the higher dose and placebo. I always like when I see these very low doses, very low response rates or remission rates for placebo. This is the maintenance of remission data up to week 52. So same story, a nice dose response with significant difference for both doses from placebo. Izencitinib is an interesting JAK inhibitor in that it is a pan-JAK, so it inhibits JAK1, 2, and 3, but because it's non-absorbable, it's felt to be safe. And in fact, if you look at these doses, this is the phase 1 program, by the way, these doses were increased up to 270 milligrams, and these are basically response rates after 1 month. If you look on the left side, a beautiful dose response suggesting that perhaps we haven't even reached the ceiling. As far as the endoscopic response, there is a little bit of a plateau, but allowing for the small numbers, this data looks very promising. So this is moving on to the phase 2 and phase 3 program. How about the safety of JAK inhibitors? So obviously more emphasis on Tofa. These are systemic immunosuppressive, so serious infections and opportunistic infections are a concern. Zoster has been seen more frequently, and it's a dose-dependent side effect. There are some lipid abnormalities, asymptomatic CPK elevation, as well as non-melanoma skin cancer, and more recently brought up the risk of venous thromboembolism. So we had first an FDA safety communication a couple of years ago. This is based on a long-term open-label study called oral surveillance in patients with rheumatoid arthritis over the age of 50 who had more than one cardiovascular risk factor and were treated with methotrexate in combination with tofacitinib 10 or 5 milligrams twice daily or an anti-TNF agent. And in that preliminary report, there was an increased risk of venous thromboembolism and sudden death in the 10 milligrams arm, reason for which everybody was switched to the 5 milligram arm of the Tofa groups. And then recently we had this FDA update at the completion of the trial. So the initial results suggest a higher occurrence of serious heart events and cancer in RA patients treated with both Tofa doses versus the anti-TNF agent. Remember again, all these patients were in combination with methotrexate. Obviously, that led to some changes in the Tofa labeling. So the indication was now put back behind failure of anti-TNF. And there is a more strong recommendation to use the 5 milligram twice daily dose and for the 10 milligram twice daily dose to be used for induction or for loss of the response and for the shortest period. Now, de-escalation is not without risks. So going from 10 to 5 milligrams, this is a post hoc analysis from the OCTAVE phase 3 program showing a taper following de-escalation, taper in the clinical response, endoscopic improvement, and remission at 1 and 2 years. So green bar 1 year and the red bar at 2 years. But what happens if we re-escalate, if we increase the dose back to 10 milligrams twice daily? Of course, most patients will recapture response and some endoscopic improvement, but herein lies the problem. So not all of them will. And in fact, only half of the patients regained remission after this therapeutic exercise of dropping and increasing the dose back. So before doing this, I think we have to think very carefully about risks and benefits. And this was further supported by this study, also in patients with ulcerative colitis. This time, however, they were in stable deep remission. So 10 milligrams twice daily for more than 2 years, steroids-free clinical and endoscopic remission for more than 6 months. And they were randomized to continue the dose or drop to 5 twice daily. And as you can see in this table, overall, the rates of maintenance of remission were fairly similar between 10 and 5 milligrams. And more so if the patient was in endoscopic remission. But if there was even a tiny little bit of inflammation, that delta widened. And if patients failed anti-TNF therapy previously, the same situation. So incomplete endoscopic healing and patients who are bio-experienced tend to do worse with dose de-escalation. So another signal, another predictor for maintenance therapy with tofacitinib. Now, speaking about the VTE risk, let's focus a little bit on patients with ulcerative colitis. So this is the safety data from the OCTAVE program, which includes the induction cohort starting from the left, the maintenance cohort up to 52 weeks in the middle, and then the long-term extension cohort. Predominant dose here was 10 milligrams twice daily, data up to 6 years. This was presented by the previous speaker, Dr. Bill Sanborn. This was reported, a couple of years ago. And if you look at the venous thromboembolism or the VTE events, there were 2 cases, one DVT, one PE in the induction trial, both in the placebo arm. Similarly, 2 cases in the maintenance cohort, both in the placebo arm, and then 5 cases of VTE in the long-term extension. Those are both in patients receiving 20 milligrams daily. But if you look at the footnote, 4 out of these 5 patients had more than one risk factor for VTE, including leg gangrene, thrombophilia, metastatic cancer, and 1 out of 5 was an overweight patient on birth control pill. So I put together here the results of several reviews. On the one hand, the risk of VTE in patients with ulcerative colitis. This is from an older review by Charles Bernstein from the University of Manitoba. And on the other hand, the results of the risk of DVT and PE with Tofa from the ulcerative colitis program, and another meta-analysis that was recently published. So if you look at the risk of DVT, overall for UC, the risk is about 1 in 330. The risk of DVT in patients with UC on Tofa high dose, 1 in almost 600, so actually less. And the overall from the recent meta-analysis, if anything, even lower. So possibly a lower risk of DVT. The risk of PE, similar, so 1 in 500 among patients with UC overall, and about 1 in 450 patients with UC on Tofa from the OCTAVE phase 3 program. Moreover, this is that systematic review that I mentioned earlier. This looks at all JAK inhibitors that are currently either in use or in development. So across the top, those are the 4, Tofa, baricitinib, which is a JAK1, JAK2, and then UPA and Philgottinib, which are JAK1 selective. So thinking whether selectivity really matters as far as the risk of DVT and PE, it doesn't seem so. But when you read this data, you have to remember that the safety data for UPA and Philgottinib derives primarily from studies in patients, or almost exclusively from studies in patients with RA, who were treated in combination with methotrexate, whereas the data for Tofa was somewhat diluted by patients from the UC program, whereas as we have seen, the incidence of VTE was lower. So how do we position, with that in mind, how do we position JAK inhibitors and Tofa in particular for the treatment of patients with UC? When we don't have comparative trials, obviously we resort to these smart network meta-analysis. And this is the updated one by Sid Singh's group at UCSD, showing that for patients with moderate to severe UC who are bio-naive, infliximab and vedolizumab seem to be the winners. Whereas for patients who are anti-TNF experienced, based on the data available at that time, Tofa and ustekinumab seem to beat the competition. So in summary, for JAK inhibitors, these agents are fast, they're effective, they have durable response, no risk of immunogenicity. There's a dose-dependent effect in both UC and Crohn's disease. Selectivity may be important for efficacy and safety, especially in inflammatory bowel disease. Dose reduction is feasible in patients in stable deep remission, and there may be a safety signal related to dose and or disease state as far as the more serious adverse events such as cardiovascular and venous thromboembolism. So with that, how would I would position JAK inhibitors? Of course, for patients with moderately active IBD, the safer agents seem to run the day. So that's where Vedo and IL-23 inhibitors have a very good place. Whereas for patients with more severe disease, whereas there is that need for speed, anti-TNF, specifically infliximab and JAK inhibitors are probably the best agents. And that was my last slide. I'll be happy to entertain any questions at the end. And now it is my pleasure to introduce the next speaker, Dr. Uma Mahadevan from University of California, San Francisco. Thank you, Uma.